From the Journal of Nuclear Cardiology, this is JNC CardioConnect, linking experts, insights, and innovations in nuclear cardiology. Let's dive into the next episode.
Hello, everyone. Welcome back to CardioConnect, the official podcast of the Journal of Nuclear Cardiology. I am Marcelo Di Carli, the editor-in-chief of the journal, and today we're discussing a paper that I think is genuinely exciting, not just because of what it shows, but also because of the timing of this information. Just a bit of context. As you all know, the current workhorse for non-biopsy diagnosis of cardiac amyloidosis is anchored on doing scintigraphic imaging with bone-avid technetium tracers. This works quite well for the classic forms of cardiac amyloid, particularly transthyretin. But we recognize that it's not perfect, and the experts in the field have been raising the questions that remain open in the field about early detection of disease. How does the tracer or this approach actually perform in all forms of cardiac amyloid? And this is where today's paper comes in. We're digging into a study that was just published in JNC on a different kind of tracer, a PET agent called Evuzamitide, and whether this tracer can help us detect cardiac involvement in rare forms of amyloid, where technetium imaging has traditionally been insensitive, even when we know the heart is actually involved. And the timing of this paper is actually quite convenient and important because just last month, Bayer announced positive top-line results for a phase 3 trial called REVEAL, a large multi-centered study on this same tracer led by Dr. Dorbala, one of our guests today. So we'll talk through today's paper, but we'll use the paper also as a window into where we think Evuzamitide is headed and what it could mean for how we diagnose cardiac amyloidosis going forward. So I'm joined today by Olivier Clerc, a clinician scientist at the Brigham and Women's Hospital and the first author of this paper, and Dr. Sharmila Dorbala, who is not only senior author of the paper, but also the research director of the Mass General Brigham Cardiac Amyloidosis Program. Olivier, Sharmila, thank you so much for being here with me today. And Sharmila, we'll start with you. Can you give us a quick rundown of how we approach diagnosing cardiac amyloidosis today? Just the basics of the algorithm. And then, where does the algorithm start to fall short? What are the gaps that really set up the rest of our conversation?
Yeah, thank you very much, Marcelo, again, for having us here. As you know, cardiac amyloidosis is a progressive and deadly cause of heart failure. The most common forms of disease that we hear about affecting the heart are the transthyretin or ATTR, immunoglobulin light chain or AL, and also a third bucket of rare forms of amyloid which can affect the heart. Fortunately, as you know, we have FDA-approved therapies for ATTR amyloidosis, which can modify the disease course. Similarly, we also have very highly effective therapies for AL amyloidosis. But at this point, the rare forms of amyloidosis have no effective disease-modifying treatments. So what is the relation between the bone-avid tracers and the new test that we're going to talk about? So a simple diagnostic approach using bone-avid tracer SPECT, as you pointed out, can avoid biopsy, and it has really led to a better understanding of ATTR cardiac amyloidosis. Patients who were diagnosed non-invasively without biopsy became candidates for treatment trials and have substantially accelerated new drug development. And the next phase of developments in therapy for cardiac amyloidosis are really fibril-depleting therapies. And we are hoping that these therapies could be effective for the rare forms of amyloid as well. Unfortunately, although the bone avid tracers work well for diagnosis of advanced ATTR cardiac amyloidosis, they are unreliable for AL amyloidosis, certain variants of TTR amyloidosis, and the rare forms of amyloidosis. And these are the patients who currently require endomyocardial biopsy for a diagnosis. So the rationale for this paper is straightforward. We really need to develop new non-invasive imaging approaches that can consistently detect all types of amyloid and not just ATTR. And closing this gap is essential if we want to develop new treatments for these patients who are currently lacking treatment options.
Perfect setting of the stage for this conversation, Sharmila. Thank you. Olivier, walk us through the study. Who did you enroll? How did you structure the comparison between your amyloid groups and the controls? And more importantly, tell us what you found in the study.
Thank you very much for the invitation. So yes, we enrolled 10 participants with rare forms of amyloidosis. So 5 of them had variant transthyretin amyloidosis, while the other ones had very rare forms such as apolipoprotein A1 or A4 or gelzoline amyloidosis, or even one case of localized light chain amyloidosis that was only in the lung. And furthermore, we also included 12 controls without cardiac amyloidosis. And this was essentially a case series, and all of them underwent evuzamitide PET-CT with the injection of the radiotracer about 1 millicurie, and then image acquisition 5 hours later. This delay is really important to give to the radiotracer the time to properly bind to amyloid or to be completely cleared from the heart, providing very clear-cut results. And the findings are really interesting. So we organized the study into 3 groups because 6 of the patients with known amyloidosis had known cardiac involvement based on echo, MRI, or SPECT-CT, and 4 did not have known cardiac involvement. And very clearly, in all patients with known cardiac involvement, evuzamitide PET-CT showed positive uptake. Very obvious visually and with quantitative metrics, no doubt, while it was completely negative in all control cases. So clearly we had an excellent separation of the cases with known cardiac involvement versus the controls. But where it becomes really interesting and challenging is what happened in the middle category, those who had no known cardiac involvement. Among these 4 patients, 3 of them showed uptake with evuzamitide. Mild, but definitely visible and also measurable with different metrics, clearly above what we observe in controls. And this is very suggestive that this radiotracer may be able to detect early deposits of amyloidosis, even in patients for whom other imaging methods are negative. However, we could not formally prove it because this would have required cardiac biopsy, and those patients had known amyloidosis based on gene testing or biopsies from other organs, and there was no clinical benefit in doing the biopsy. But nevertheless, this is highly suggestive given previous results on this radiotracer, high sensitivity, high specificity, that we can even detect doses at an early stage when amyloid deposits are starting. And those are extremely encouraging results showing that this radiotracer can also be used in the more rare forms of amyloidosis, not only in wild-type ATTR or AL amyloidosis.
Thank you, Olivier. As you were describing your results and some of the challenges on having a potentially super sensitive tracer, how do you measure that against, right? I mean, setting what is the gold standard for making the diagnosis, and is it easy to do this when you're validating a new approach? And I think you're showing here some of the challenges for that. So thank you. Sharmila, stepping a bit back, what do you think these findings mean for how we think about this idea that a tracer might pick up disease before any of our conventional tools do? But looking ahead, if evuzamitide gets approved by the FDA, do you think that there's a realistic pathway for the approval to apply also to rare forms of the disease? Or do you think we're going to need to do more clinical trials to test that this also applies to these forms that Olivier just described?
Yeah, excellent questions. And Olivier, really nice summary of your work. Thank you so much. So the implications of this work are truly exciting, especially when you want to combine it with the results of the REVEAL trial that you have alluded to. So Dr. Jonathan Wall, who invented this compound, and Dr. Matt Morer's group, as well as our group, have now compiled some data showing that evuzamitide has the potential to image amyloid across a wide range of precursor proteins, and not just the typical ATTR cases that we're detecting with the bone avid tracers. So the REVEAL trial enrolled patients with suspected cardiac amyloidosis from any precursor protein and asked a very simple question: can this tracer accurately diagnose cardiac amyloidosis regardless of the type of amyloid? And as you pointed out, the answer was yes. The study met its primary sensitivity and specificity endpoints. And this is really exciting because AL amyloidosis, as well as the rare forms of amyloidosis, have historically to date needed a biopsy for diagnosis. So all of this could change if this tracer is approved and becomes available clinically. So instead of having one imaging modality for ATTR and a completely different and often a biopsy-based pathway for AL variant TTR or rare forms of amyloidosis, we could be looking at a future where we have a single test, a single tool for detection of amyloidosis across the spectrum of the precursor proteins. And as Olivier pointed out, this means not only accurate diagnosis, but potentially earlier diagnosis, a better assessment of disease burden quantitation because it's a PET tracer, and potentially longitudinal disease surveillance using these quantitative metrics. And of course, another important clinical implication that I want to underscore is that a pan-amyloid imaging agent could lead us to identify more rare forms of amyloid patients that we are currently not detecting. And this has a potential to accelerate clinical trials, as we have seen with bone tracers, bone avid tracers, and TTR amyloid. So these could accelerate clinical trials to develop disease-modifying therapies for these rare forms of amyloid for which we currently have no treatments at all. So all in all, I think it's a very exciting time for amyloidosis, probably the start of a new era where we are looking at a novel imaging-based approach to diagnose all types of amyloid at an early stage and also follow disease burden longitudinally with time.
Just a quick follow-up question. Do you think that if the tracer is approved, it will apply to all forms of cardiac amyloid or just the forms that were tested in the trial?
So that's an excellent question. I don't have the full results of the study yet, but when we have it, we'll have a better understanding of how many rare forms were included. And then, of course, the FDA would take into account not just the results of the REVEAL study, but would also look at the entire body of evidence to date, including the single center investigator-led studies, and make a final decision. We are hopeful that they will look at the totality of the evidence and make a decision based on that, but we'll need the full results to know that answer.
Okay, right. So, Olivier, for the clinician listening to this conversation and who has a patient that has one of these rare forms, maybe a mutant form of TTR, maybe a family member and the patient is being followed, what is the one thing that you want that clinician to know and walk away from this paper in terms of implications? And practically speaking, this is an investigative tool. So the question is, what can we do today versus things that we can do when this technology gets approved?
Indeed, so this is a great point because patients with rare cardiac amyloidosis can have very atypical findings in cardiac imaging, so it can be very difficult to diagnose the disease. They may have a heart failure with unclear finding, and then you don't really know what to do. And currently, the only way to be really sure that there is amyloid is to do with a myocardial biopsy. But hopefully soon we will have this tool available that will allow us to really detect any form of amyloidosis in the heart, and that can really help in those situations where you have an unclear heart failure to kind of reorient the diagnosis, as well as to detect which organs are involved. And furthermore, it could be very useful in patients who have a known gene mutation who are not sick yet. But then with this radio tracer, you can assess if the heart is starting to be involved or other organs, and this might in the future help to determine the moment at which a treatment would be needed. So I think those are exciting prospects for the future, and hopefully this investigative tool will soon be FDA approved for clinical use.
Thank you so much, Olivier and Sharmila. This is a very exciting time for our field, in particular to the field of cardiac amyloid, and I think for the field of molecular imaging in general, because, you've demonstrated what can molecular imaging change that is tangible and with strong clinical implications beyond the research interest. So thank you for your leadership in this area. Thank you also for choosing JNC for publishing your work. I think this is really great to have novel approaches to imaging. Now, for folks listening, you just heard it from the authors. You can read in JNC the details of the paper. You can actually look at the images, which are quite interesting and exciting. And for those of you listening, if you like what you listen, please share with your friends and drop us a comment about things that we can do better, we can improve on our podcast and our discussions that we're having every month. So with that, thank you both again for your time this morning and for publishing this excellent work, and for our audience until our next episode. Thank you.